Thank you very much, and thanks, Ben, for setting me up. I hopefully will be able to make up some time, but I don't know for sure. Okay, so um, we need somebody to get my presentation. Okay, perfect. Thank you very much. All right, you can start the timer again. No. um, So just to be clear, this is what we're talking about. This is a system. It's not just it's a system that's been designed for each component to work with the other. And the current sensor is the G4S, which is sitting just below the pump. But we have two new sensors, and we have the Simplera, which is a fully disposable sensor, much easier to apply. It lasts for us up to 7 days. And Instinct, which is made for us by Abbott. It's essentially the Libre 3 Plus, but you buy it through us. We maintain the support for it. So in the end, we're just you just have one person to call to be able to, if there's a problem, to help answer your questions. So 780G is probably the most studied pump system ever. And I don't expect you to know all of that, but or even read most of these papers. Most of these papers are done by people who are not Medtronic employees. These are individuals, independent investigators. And at this point, I made this slide up just at the end of last year. I think this number is probably up to about 260. And what the data shows, and we had a discussion about this earlier after my talk this morning, is that it doesn't matter what country you look in, what gender the person is, what their age, children or adults, what their baseline glycemia is. This system democratizes insulin and glycemic management. And that's because of that algorithm that Ben so nicely described. Those auto corrections are the main mitigating factors. So if you forget to take a meal, if you bolus, do remember, but you bolus late, or you forget how many carbs or don't accurately calculate them, it has your back. So here's the data. You already saw this, so I'm not going to spend any time, but at this point, there are over 400,000 users of the 780G across the world. And this is actually the data in people with type 2. This is real world data, just like the previous one was. And these are type 2 who are self-identified, who are taking over 100 units a day. So we're pretty sure they're type 2. And this is in about 3,500, 3,600 users. And you can see people using the optimal settings get a boost of about 6%, just like the data Ben showed you, using those optimal settings of a target of 100 and an active insulin time of 2 hours. So Ben said he reviewed the data for India. I put this on a slide, and you can see, if you remember what you saw from his slide across the different countries, this is almost identical, 1,300 users in India, and they're getting almost identical to results as every other country, Western Europe, or wherever you are in the world. Now, the simplicity of this is really very, I think, very important, because the clinician, as there are other systems out there, we have to spend a lot of time setting things up and putting in the various insulin sensitivity factors and so forth. Here, the main thing that you have to do as a clinician is get the settings right. And there are only really two settings that you have to get right, and that's the basal target and the active insulin time. What is a person's with diabetes? What's their responsibility? To give a bolus. This is indicated for people to announce the meals and give a bolus. And we know, of course, that doesn't always happen. And to respond to the alerts. These are safety features that are put in for a variety of reasons. And the number of alerts has been greatly reduced compared to what we had in the 670 and 770. The exiting from automation, SmartGuard into manual is now down to about 0.1 per week. So over a period of a month, you may get exited about once. Now, to help the clinician take someone from MDI to using a pump, we have a setting sheet. So I'm not going to go through this, but this is very straightforward. Take you about a minute or so to fill this out. This will give you an idea of what the pump total daily dose would be, the basal rate, meal bolus, and sensitivity factor. And this is followed up with another worksheet, which you can put in all the initiation of settings. And so if you're not doing the pump training, the pump trainer can help with this, and the patient can see how to program the pump. Now, one of the most useful things to get used to using a pump is this virtual pump exercise. So if you want to get out your phones and look at this QR code, you can take this home and you can play around with how to set this pump up. And I'm not going to give a live demo, but you can just play with it and see how to set this up and how this works. And it's very responsive, and it's a lot of fun to use. Ben showed you this. The CareLink reports are really key to getting the best outcomes in patients, and there's a 1, 2, 3 method. So review the goals. If the goals aren't met, you look at some of the other pages, and then there is a manual mode, and you always want to be aware of, if you should get exited, that those manual mode settings are correct. So let's just go and look at a few of these in more detail. Here's the assessment and progress report. So a lot of information on here. The top is the glucose data, and bottom left is the time and range. The first 2 weeks, or most current 2 weeks. It could be most current week. You can preset that. The default is 2 weeks, and the B column is what was the 2 weeks before that. And then there are a whole bunch of statistics. You actually can just look at this one page and really figure out what's going on. So statistics are trying to look at how the outcomes that the patient has experienced match up with what the goals are as established by, American Diabetes Association and other professional organizations. So here's blown up, on the left, the time and range, and on the right, you see all the statistics. So the first 3 I've highlighted is the SmartGuard. What percent of the week are they actually in automation? This person is great, 99% of the time. The sensor wear, 98% of the time. The GMI, wonderful, 6.6%. Here, going down, what I've highlighted is the auto-correction amount. So this is the percent of all bolus insulin that is auto-correction, and this is 37%. The lower the better. In the pivotal trial, it was 22%. Anything over 30% means that there are some issues that are going on, and why is this autocorrection working so hard? We'll show an example of that shortly. And then the active insulin time and the program manual basal and the SmartGuard target are at the bottom, so you can look to see if these are set correctly. Now, if the person's reaching their goal, yes, make sure that the manual mode settings are correct, and you're done. So as patients come back and you refine this, and I'll show you a case study, there's not much to do. And as Ben said, and as I like to say, the conversation is very different. It's not, oh, what did you eat on Saturday night that made your sugar go up? It's, well, how are you? And what's going on in your life that's stressing you out? And are you checking your feed every day? Did you get your annual eye exam? And things that are medically related and psychosocially related that may actually be more important than actually a single glucose. And frankly, this therapy is so impactful that you're not going to be talking about this. Now, if they aren't reaching their goals, you review the therapy. So there's what's highlighted here that in pink are some of the things that you should be looking at, like the device settings. So look at the device settings. There's a meal summary, a weekly summary, and a daily summary. The meal summary is actually an analysis that looks at when the bolus was given with respect to when the glucose was going up. So you can clearly see for this individual, the bolus count is 8, so that means 8 lunches. And you can see that the bolus was given for the most part in the middle of the meal because the sugar was already going up. And why is that important to note? Well, look at the hypoglycemia that happened an hour and a half or so, or 2 hours after the bolus. So if you give a late bolus, it's not uncommon to see some hypoglycemia afterward. And then you look at a weekly report, and the weekly report tells you a lot about behaviors. So if you look in over here, you see that there's a lot of autocorrections. We don't know why. It looks like probably breakfast was a missed meal bolus. And here's blowing up. Ben already showed you an example of this. This person bolused just once around 3 o'clock, but obviously ate breakfast and lunch because you see these rises. And the autocorrections are kicking in and mitigating the severe hyperglycemia that you would otherwise see without the autocorrections. So the way to think about this is if you look at if the person's spending 25% of or more time above range, it could be that the recommended settings aren't being used, that the boluses are being missed or delivered late, or the carb ratio needs to be strengthened. And the system adapts. And you want to, anytime you make a change, you want to wait a couple of weeks before you reassess and see if what you've changed has made a material difference. On the other side, if the person has hypoglycemia, less than 70, 4% or more below range, there are a number of things to consider. Where the bolus is late or the carbs overestimated. Carb ratio may need to be weakened. A temp target may need to be set. So there are a number of, and this is a very logical procession of analysis, and it can really be quite straightforward and simple. So here's a case where this person's time in range is 67. We would say they're not meeting the goal of the professional societies, which is over 70%. And look at the percent of autocorrections as a function of how much bolus insulin there is. 84% of the bolus insulin is being given by autocorrections, which means, right, you can look at this and say, well, the patient may not be announcing their meals, or maybe the carb ratio is not strong enough, so the autocorrections have to kick in. So what can a patient do to best optimize the system? We drill this into everyone we talk to, for patients and healthcare providers. Target of 100, that's the default, and an active insulin time, a misnomer, as Ben explained, of 2 hours. Why 2 hours? This is really a really interesting study in which they changed the active insulin time from 2 hours, 2 weeks, 3 hours, 2 weeks, 4 hours, 2 weeks. And you see what happens is that the time in range goes down from 74.5 down to 68. And the time below range doesn't really change the more aggressive you make this algorithm with the 2-hour active insulin time. So in the last 30 seconds, I'm going to show you a case. This person has type 2 diabetes. They switched to the 780 from MDI and intermittently scanned CGM, so that's Libre. A1C prior to switching was 13.5. Time in range prior to switching was 6%, with 94% time above range. And here's what it looks like the first visit back after SmartGuard was activated. And this is after 2 weeks. So the time in range is 53%, not ideal. And why is that? Well, there's a lot of activity going on here below, a lot of probably double bolusing or auto or self-correction. And the bolus timing looks good, but here you see what's happening. So for instance, up here at the top, this patient took a bolus before the meal, but the glucose went up, and you see all these autocorrections. So what that tells me is probably the carb ratio wasn't set more as aggressive as it should have been. And then you want to always update manual mode. This person had on the bottom a total daily dose of 229. So you would think that in manual mode, the basal rate should be about 115, but actually it's set at 57. So if the person gets exited from automation SmartGuard to manual mode, you want to be sure that that basal level is approximately half of what the TDD is. And then here's what happened. So the carb ratio was changed from 5 to 4.5. SmartGuard target was decreased from 120 to 110. A week after this was done, the time in range went up to 74%. And after 3 months, the time in range is up to 87% and 77 the 2 weeks before that. And you can see virtually no hypoglycemia. So this is an iterative process, and you can use the various settings to help get the best results. So I'm going to stop there. I had another case, but we have Dr. Jatha Deb to do that. So thank you very much.
Thank you, Bob.